Welcome to the third in a series of short videos from the CoSRH looking at emergency contraception. In the previous two videos, we discussed how to assess pregnancy risk and how emergency contraception works. In this video, we will discuss how, through a joint decision-making process, we can advise which emergency contraceptive is most suitable for the individual patient that is consulting us. We have learnt that pregnancy risk is greatest if unprotected sexual intercourse takes place in the 6 days leading up to and including the day of ovulation. Oral emergency contraception works by delaying ovulation, and the copper IUD works by preventing fertilization and implantation. The copper IUD is by far the most effective form of emergency contraception and should be offered to all individuals who are eligible. Remember, a copper IUD can be fitted as long as all episodes of unprotected sexual intercourse have occurred either within the last 5 days or you are fitting the IUD within 5 days after the earliest predicted date of ovulation. As in both of these situations, implantation cannot have occurred yet. However, some individuals will choose not to have a copper IUD and instead opt for oral emergency contraception. We have two types of oral emergency contraception, levonorgestrel and ulipristal acetate. You may sometimes hear these referred to as EHC, or emergency hormonal contraception. Ulipristal is licensed for use up to 120 hours after unprotected sexual intercourse, in contrast to levonorgestrel, which is only licensed for 72 hours. To be effective, levonorgestrel needs to be taken before the LH surge begins, but ulipristal is still effective if taken after the LH levels have started to rise. Ulipristal is also more effective than levonorgestrel. So, does this mean ulipristal should always be our first choice of oral emergency contraception? Let's look at some factors which will influence our decision. Ulipristal works by binding to progestogen receptors. If these receptors are already blocked with progestogen, it is unable to work. Thus, if the individual has taken any progestogens in the previous 7 days, then ulipristal may not work. Similarly, if any contraceptive hormones are started in the 5 days after taking ulipristal, they may displace it from the receptors, making it less effective. This means that we must delay starting ongoing hormonal contraception for 5 days after giving ulipristal. This is not the case with levonorgestrel, and ongoing hormonal contraception can be started immediately. With both types of oral emergency contraception, when the individual does start ongoing contraception, either immediately or after 5 days. Remember, the new method will need its usual period of time before it is effective. That's 7 days for most COCs and 2 days for most POPs. Both types of oral emergency contraception can be used more than once in a cycle. But if the individual has taken levonorgestrel, she cannot then take ulipristal in the following 7 days, as levonorgestrel is a progestogen and may block the progestogen receptors, stopping ulipristal from working. And if the individual has taken ulipristal, similarly, then levonorgestrel cannot be used in the following 5 days. So it's important to ask people whether they have taken any oral emergency contraception within the last 7 days, as well as whether they have used any other regular contraception. There are some other things to consider when thinking about emergency contraception choice. There are a few circumstances where a double dose of levonorgestrel, ulipristal, is never given as a double dose. If patients are taking enzyme-inducing drugs, then oral contraceptive hormones are less effective. A double dose of levonorgestrel could be tried, but its effectiveness is unknown, and a copper IUD would be a much better option. We know that levonorgestrel is less effective in patients whose BMI is greater than 26 or who weigh more than 70 kilograms. These patients will need a double dose of levonorgestrel. The absorption of ulipristal may be reduced if the gastric pH is raised, as in patients taking antacids or proton pump inhibitors. If ulipristal is given to someone who is breastfeeding, guidance suggests the breast milk should be expressed and discarded for 7 days. Ulipristal is contraindicated in patients with severe asthma on oral steroids. So, which form of emergency contraception do we advise? Always offer a copper IUD if eligible, as it not only gives the best emergency contraception, but also offers highly effective immediate ongoing contraception. If there is going to be any delay in fitting the IUD, offer oral emergency contraception if within the correct window, just in case the IUD cannot be inserted or the patient changes their mind. All emergency contraception needs to be taken at the earliest opportunity to be most effective. You can offer oral emergency contraception if there has been an episode of unprotected sex earlier in the same cycle as well as within the last 5 days, as evidence suggests that oral emergency contraception does not disrupt an existing pregnancy or cause fetal abnormality. Assuming no contraindications, ulipristal is the best option if the individual is close to the time of ovulation and thus at high risk of pregnancy. Consider ulipristal if someone presents between 72 and 120 hours after the most recent episode of unprotected sex, as levonorgestrel is only licensed for use up to 72 hours. Levonorgestrel is preferable if any progestogen has been taken in the last 7 days. If it is imperative that ongoing contraception is established as soon as possible, then using levonorgestrel also allows immediate quick start of a hormonal contraceptive method. After you have provided oral emergency contraception, there are a few additional things to discuss. If vomiting occurs within 3 hours of taking oral emergency contraception, then a repeat dose is indicated. It is good practice to advise a pregnancy test 3 weeks after the last episode of unprotected sexual intercourse, or if the next menstrual period is delayed by more than 7 days, is lighter than usual, or is associated with abdominal pain that is not typical. We hope you have enjoyed this series of 3 short videos about emergency contraception. They are intended to support your clinical practice, but do not provide a qualification to deliver services. You must always work within your levels of competence. For further information about all aspects of sexual and reproductive health, including up-to-date guidance and information about our qualifications, please see the CoSRH website at www.cosrh.org.